So today we are going to see the gynecology, pathology, and breast. I say gynecology and breast because breast now is not included in gynecology, because the breast is for male and female. Some people, they think that breast is for female. It is not true. Breast disease is now in surgery, not only in gynecology, because the breast disease are similar in male and female. So we are going to start by the female genital system pathology. I don't have done the anatomy of the female genital system. I've also done the histology. So I think now you are comfortable to understand those. That is the physiology of the female genital system. There are some people disturbing us. Please unmute yourself. Okay. So this is the female genital system. This is anatomy, and we have done the physiology. And you still remember that the vagina, body of the uterus, fallopian tube, and the ovaries. Let us start by the disease of the vulva. In common for those disease, there's some inflammation, benign tumors, and malignant tumors. For this one, for the inflammation, there is what we call virivitis. This one, they say it is more common but not serious. There are some non-neoplastic epithelial disorders, and then carcinomas. These are uncommon, but they have a poor prognosis. Another one disease of the vulva is the Barton Cysts. This one is common. Barton Cysts, you will see even in your gynecology course. This one is caused by obstruction of excretory ducts of Barton gland. So I've seen the virivitis. Virivitis is caused by some viral bacterial infection. The most common is HPV, human papillomavirus. And then there is herpes genitalis, 1 and 2, there are 2 types. Then they cause vesicular eruption. There is some gonococcal spirative, even syphilis, and the fungal infection called Candida. Those they can cause an inflammation of the vulva called virivitis. So meaning that clinically you see some lesion on the vulva, and to confirm the diagnosis, you send the sample to the lab. You can do a biopsy or some culture of those bacteria and the virus. Vulva, it has one part of the skin. This is why you see some disease of the skin like dermatitis, inflammation of the skin. It can be on contact or allergic. This one you will see them in dermatopathology. So those contact, most of the time they can be used to soap, antiseptic, alcohol, perfume, lotion, and others. Those they can cause virivitis due to the contact dermatitis. So it is not advised to use more soaps, lotion on the valve. Most of the time it can cause the allergy and it can cause contact irritant dermatitis. There are some non-neoplastic epithelial disorders where there is atrophy of the vulva. This one, it is not very common. It is seen also, it is like the disease of the dermatology where there is lichen sclerosis, lichen simplex. This one, you will see them again in the dermatology. But you can see some images of those lichen sclerosis and lichen simplex chronicus. This one, it is like a disease of the skin. We see them again in dermatology. Some tumors, the most common tumor of the vulva is called condyloma. Those condyloma, they are caused by human papillomavirus, known as HPV. And they are low risk because they are high risk HPV and low risk HPV. Those condyloma, the most common is Condyloma acuminata. This one, it is very, very common and it is precancerous. Is what we call vulvar intraepithelial neoplasia. It can be graded 1 until 3. Until 3, it is malignant. But most of the time, the condyloma is malignant. And to diagnose a condyloma, it is very, very easy. As you see even on this image, here it is a condyloma. It is like a cauliflower, what we call in French chou-fleur. This is when you see this image, fingerting this like this one, be sure that you are dealing with a condyloma. And to confirm this one, you have to take biopsy and then you send for lab for analysis. The condyloma, I have said, they are caused by low risk HPV. There are several types of human papillomavirus. There are more than 72, around 100. So for this one, the most common HPV type 6 and 11. Most of the time, they are the main cause of the condyloma. This is an image of a condyloma. Even this one was on the condyloma where there is some coilocytics, this one. Those squamous cells with a clear halo. This is the macroscopic. You see this one, cauliflower tumors. And this one, it is on the histology, characteristic by this one, coilocytic changes, squamous cells with clear halo. So once you see this image, you did say that there is HPV. And about HPV, it can be diagnosed on the biopsy. It can be diagnosed by a DNA test. Most of the time, it is a DNA test. You will see it when you start your internship in the lab. You will see some HPV DNA tests. This is histologic image of the condyloma. There's some tumors, like those high-grade vulvar intraepithelial neoplasia or carcinoma. The most common carcinoma is the squamous cell carcinoma of the vulva. 9% they are squamous cell carcinoma. 90% of them, they are related to HPV. There is another disease called Extraomar target disease. This one, it is not common. It is macroscopically, it is red scar plaque characterized by spread of malignant cells within the epithelium. But when you have an image, it is where it is clear. Those cells, these are target cells. It can be even found on the nipple of the breast, but also it can be also found in the vulva. So don't be surprised when they say target cells on the vulva. And when it is for the breast, in that case it is malignant. For example, here, these are target cells. This one you have seen. You can use also some special staining like periodic acid sheet to distinguish from that the melanoma. But this one, it is seen in practice. So here there are some review of questions you will do it when you are at home. For the vagina, it is somehow similar to the vulva. There are some inflammation, vaginitis, some benign tumors, and malignant tumors. There's some congenital anomalies. You have seen it in your embryology. You can even have an absence of the vagina, but those anomalies are not common. Vaginitis, it is a common, and most of the time it is caused by Candida Albicans and Trichomonas vaginalis. So what you have to know here is to differentiate on your examination, physical examination, to differentiate infection from Candida albicans and infection from Trichomonas vaginalis. Candida vaginitis, it is white discharge. Wherever you see the white discharge, make sure that you are dealing with the Trichomonas, the Candida vaginitis. This one, it is common. And then for Trichomonas vaginalis, it can produce a watery, copious green discharge. In this one, once you found the Trichomonas vaginalis, you have to treat the couple, because this one is the sexual transmitted disease. For the tumor neoplasm, we have vaginal intraepithelial neoplasia and squamous cell carcinoma. And these are common. Even in our settings, you see some the squamous cell carcinoma and the vaginal intraepithelial neoplasia of the vagina. They are also, as they are associated with the HPV. And what you must know, HPV is sexual transmitted disease. HPV is not for female. Even for male, you have seen some cases of squamous carcinoma of the penis due to HPV. Meaning that once you found HPV in the family, you have to treat the couple, woman and husband, because Male also are on the high risk of getting HPV infection, but most of the time on TV in public health, they focus on the female and forget male. As a medical student, you must know that male are also on the high risk. We have published one article about the cancer of the penis, and you have seen it was related to HPV infection. So the most common tumor is the squamous cell carcinoma. There's a vaginal adenosis. These are not common. It is like an inclusion, and they appear in vaginal mucosa as red glandular foci lined by mucus secreting cells. So this one is not common. Here there's some question. You will see them for review. So before we go to the cervix, any question about the vulva and the vagina? Any question? Any question? Any question?
Yes. I have one question.
Yes, you're welcome.
Yeah, you said about Candida Albicans. We must observe it by seeing this white discharge. What about Trichomonas?
Trichomonas, it is watery and somehow green. The discharge is somehow water,
Yeah.
and the color is somehow green.
Thanks.
Question, Prof.
Yes.
You said, I want to add about the Candida Albicans. You know, women normally they have the white discharge. How can you differentiate it, the normal one and that one which is abnormal?
For the abnormal, most of the time, there are some clinical features related. Most of the time, there is itching and the bad smell. So in that case, it will be even painful. So it will be like the pruritus.
Okay, thank you.
When you want to diagnose, to confirm the diagnosis, you take a swab and then you send the sample to bacteriology lab, then they identify. So in microbiology lab, then they identify if it is a parasite or if it is a fungal infection. So wherever you see the discharge, please take a swab for lab analysis. Then they will tell you which microorganism is involved. And for the tumor, you take a biopsy. So let us go to the cervix. I don't make a review of histology. I think you know the cervix. It has ectocervix and endocervix. Ectocervix is run by squamous cell, whereas endocervix is run by columnar cells. So as the vulva and the vagina, cervix also it has inflammation. This inflammation is called cervicitis. This is the most common, and this one is painful for female, and it is caused by some infection. And there is also what we call Boson Cyst. This one is the dilatation of endocervical gland, and most of the time it is related to age. Over 55 or post-menopause, it is where you see some cases of Boson cyst. Virivitis, as I say, is caused by some microorganisms. Streptococcus, Staphylococcus, Escherichia coli, Chlamydia trachomatis, Trichomonas, Neisseria gonorrhea, herpes, and HPV. These are involved in cervicitis. Cervicitis is painful, and once you suspect cervicitis, you take a small sample on the cervix. Then for histopathology, we will see that there will be inflammatory infiltrate, and then you confirm this one is cervicitis, and then you go to the treatment according to the microorganism identified. For this one, cervicitis, you can make a biopsy or a swab for microorganism analysis. Endocervical polyp, these are benign tumors. They are also protruding mass on the endocervical mucosa, and they are very, very common. In our settings, we see several cases of endocervical polyp. In this one, they are benign tumors. They are about a few centimeters, maybe 1 centimeter or 2 centimeters. A Boson cyst, I have seen it is a blockage of endocervical gland secondary to inflammation. And this one, the Boson cyst, is a benign tumor. Tumors of the cervix, the most common is squamous cell carcinoma. This is the most common cancer of the cervix. But with this screening of cervical cancer, as we have seen in cytopathology, we can reduce the mortality related to the squamous cell carcinoma using the pap smear. We have seen it in the last time. This is an image of the normal cervix. Sorry, not normal cervix. This one is the normal, but here it is a squamous metaplasia. In this one, it is a transitional zone. This one, normally it should be columnar, but as you see, there is a change, starting being like a squamous. We have seen it in general pathology. Cervical intraepithelial, what we call CIN, can be CIN1, CIN2, CIN3. I've seen it in general pathology. CIN3 is like a carcinoma in situ. Most of them, they are caused by HPV. It can be low risk or high risk. And the peak incidence of CIN is about 30 years, whereas that a carcinoma is about 45. The risk is early age at first intercourse, multiple sexual partners, and HPV. But most of the case is HPV. We have seen it. This one is exfoliated superficial squamous cells. You see this one, those squamous cells, intermediate, and see this one, superficial. CIN1, or in cytology we call low-grade squamous intraepithelial lesion. CIN2, intermediate or high-grade squamous intraepithelial region. You see now the cytoplasm, so the nucleus is increasing compared to the previous one. And this one, it is CIN3 carcinoma in situ. On the microscope, you see, on the pap smear, you see it is high-grade squamous intraepithelial region, high C or low C. You see now it is like you don't see the cytoplasm. This image you have seen it in general pathology. This is one is CIN3, but the membrane is still intact, meaning that once you remove that tumor, there will be a good outcome. There will be a good prognosis. Treatment of that CIN, there are different type of treatment of this region. There is what we call colonization. You remove that part infected, electrodiathermy, cryosurgery, laser, or electrosurgical excision. This one you see it in your gynecology course. This one it is under colposcopic guidance. You will see that colposcopy in your gynecology practice. About HPV, there are some high risk and low risk. This is why when you suspect HPV, it is better to do the HPV DNA test. With that HPV DNA test, you will identify low risk and high risk. Low risk, it will found those condyloma and the others. In the high risk, like 16, 18, 45, and 31. This one, they contribute to the carcinoma. They say the viral DNA integrate into the host genome and express E protein and E7. This one, you will see it in your molecular biology.
Yes, we can.
Yes.
Okay. So with that HPV DNA test, we identify those type of HPV low risk and high risk. This is an image where you see those cholestic changes, this clear arrow on the image. You see here some atypical cells which are hyperchromatic and pleomorphic. And this one, it is intraepithelial lesion with HPV infection. So the malignant one, what you call invasive carcinoma, the most common is squamous, and it is followed by the adenocarcinoma. Adenocarcinoma on the endocervix, squamous carcinoma on the ectocervix. This is an image of the squamous cell carcinoma. This one around those are lymphocyte, meaning that there is infection. And this one, it is a malignant cell. You see now the cells are pleomorphic. Some are small. They have changed even their morphology. So, as we have seen in the general pathology, after diagnosis of a cancer, you have to make a grade and staging. Grade is about the morphology of the cells, whereas the staging is the spread of the tumor. In gynecology, there is what we call FIGO. Staging is done in a system called FIGO. FIGO means that Fédération Internationale de Gynéco-Obstétrique. This is what we call FIGO. It is not a FIGO like a former footballer in Real Madrid and Barcelona. This one is Fédération Internationale de Gynéco-Obstétrique. So I don't ask to memorize those staging because there are several types of staging. You can't memorize. But what you must know, there are four degrees of staging. Stage 1, 2, 3, and 4. 1 and 2, they are early stage. 3 and 4, they are advanced stage. For example, if you say stage 1, A1, confined to the cervix, diagnosed only by microscopic with invasion of inferior to 3 millimeters in depth and lateral spread of 7 centimeters. This one, it is done by a pathologist. Pathologist is qualified when we report to add the extent of the tumor staging. For example, advanced can spread to adjacent organ or spread to distant organ. We have seen one case with a cervix metastasizing to the colon. It can even go upper from the cervix until body of the uterus. It can also involve in the parametrial tissue, like those adjacent fat in the other organ around the cervix. And it can also be involved in the lymph node. Okay? The tumor was on the cervix, then we found some metastasis in the lymph node. The spread I have said, lymph node, parametrium, urinary tract, uterosacral ligament. It can be the site of metastasis. Treatment is surgery, and then you combine radiotherapy and chemotherapy depending on the stage. So what you must know of today about the cervix and the gynecology, it is that FIGO staging. We see there is a FIGO for the cervix and there is a FIGO for even for the ovary. And what you must know, the treatment is surgery combined with chemotherapy and radiotherapy. And you must also know the low risk and the high risk HPV. These are very, very important for you. Any question about the cervix before we go to the body of the uterus and the ovary? Any question? Any question? Can you hear me?
Yes. Yes, we can.
Yes, we do.
Any question?
No question, I guess.
Okay. So we can now see the uterus, ovary, fallopian tube, placenta, and the pregnant disease. Let us see the body of the uterus.
Question first.
Question?
Yes, I have a question on the cervix about the way we do staging. We used to know the normal way of staging tumors on other cancers. Then why is it different from that one of the cervix?
Sorry?
The way we grade the tumors on the cervix.
We grade or we stage?
We stage.
What is the question?
The question is the normal way of staging tumors that we knew.
That one, TNA, tumor nodule metastasis.
Yes.
This one, the TNM is the most common, but there are other systems of staging. For gynecology, the most common system of staging. You can also use TNM, but the most common that system of Fédération Internationale de Gynéco-Obstétrique. Okay? So in summary, there are several types system of staging tumors. Okay?
Thank you, Prof.
Okay. For the body of the uterus, the same as of the cervix, there is inflammation, benign tumors, and malignant tumors. Where you see here the endometritis, this is an inflammation caused by the microorganism. This one is a kind of review of that histology of the endometrium. We see here the stratum compactum. We have the endometrial gland, stratum spongium, and stratum basalis, and here there is muscle. And here there is epithelium. Endometritis, it is an inflammatory process caused by some gonorrhea, chlamydia trachomatis, and others. It can be acute or chronic. So this is why there's endometritis. You take a sample on the endometrium, swab, or the biopsy, then you send for lab analysis. Then they tell you it is an inflammation, and the microorganism is involved, is this one. Endometritis presents with fever, abdominal pain, menstrual abnormalities, infertility, and some ectopic pregnancy due to the damage of the fallopian tube. You can also find some granulomatous endometritis. Another one is adenomyosis. Adenomyosis is not an inflammation. It is that those in the cervical gland, they go and then they enter in myometrium. For example, adenomyosis, those gland, you found those gland, here it is on the mucosa, but you can find those gland in the myometrium here. And this one will cause bleeding, and it is caused as adenomyosis. So adenomyosis may produce menorrhagia, dysmenorrhea, and pelvic pain on the onset of the menstruation. This one, it is very, very painful. But the main sign is pain and bleeding. There is also called endometriosis. This one, it is a location of endometrial gland outside the endomyometrium. It can be found in the ovar, even in the, we have also seen some cases of endometriosis in the intestine. Manifestation depends on the distribution of the lesion. It can be in the ovar. This one can produce discomfort in the lower abdomen, abdominal quadrant, and eventually can cause sterility. It can be found in the intestine, where there is pain on defecation, reflect the rectal involvement. So in that case of endometriosis, there is dysmenorrhea, pelvic pain as a result of intrapelvic bleeding and periuterine adhesion. So in summary, endometriosis is the location of the endometrial gland outside of the endomyometrium. Here there is the image of the common site of the endometrium. And here microscopic section showing the adenomyosis. There is what we call in gynecology dysfunction uterine bleeding. This one is dysfunction uterine bleeding. It is complex. It has various causes. It can be failure of ovulation, inadequate luteal phase, contraceptive-induced bleeding, endometrial disorders, including chronic endometritis, endometrial polyp, and the myoma. This one is called in general, you will see in your practice, dysfunctional uterine bleeding, because you see bleeding, but you can't identify clinically the cause. This is what they are called dysfunctional uterine bleeding. Another one, benign, what we see common is endometrial hyperplasia. This one, they can be classified into simple, complex, or atypical. And when you see a female in menopause with uterine bleeding, think about endometrial carcinoma. And when you see it is endometrial hyperplasia in menopause, it is better you remove that uterus because it will end up to the carcinoma. I said the common risk factors is obesity because of adipose tissue and steroid processes into estrogen. But this is the risk, but the common cause is not well identified. But what you must know, endometrial hyperplasia in menopause, it is a high risk of having endometrial carcinoma. So when you see a bleeding in menopause, please pay attention. It must be a high risk of a cancer. This is a simple hyperplasia. To know the hyperplasia, you must know the gland, endometrial gland, to stromulation is greater than 1. You see now we have more endometrial gland than a stroma. And also there is an increase of cellularity on the gland. For this one, it is endometrial hyperplasia, but there are no atypical cells. For this one, it is a complex atypical hyperplasia. You see, it is like you don't see the stroma. And the gland has changed the shape, and there is an increase of cells. So for this one, it is complex atypical hyperplasia, and this one can lead to cancer. Another tumors, there's some endometrial polyp. It is like we have seen on the cervix. For this one, they may occur at any age, but more commonly, they develop at the time of menopause. In the clinical significance, there is production of abnormal uterine bleeding. This is why when you see uterine bleeding in the menopause, please pay attention. This is the benign endometrial polyp. They show a cystic dilatation. This is the epithelium. This is the lumen of the cyst. This one is the stroma. And there's some scattered lymphocytes. The most common benign tumor of the body of the uterus is what we call the myoma. These are benign tumor of the myometrium. They are most common. Are found in 30 to 50 of the women during reproductive life. You will never see leiomyoma in menopause. Because they are induced by estrogen, and in the case of the menopause, there will be diminution of the estrogen. This is why leiomyoma they shrink in postmenopausal. There will be shrinkage of that leiomyoma. To operate leiomyoma in a reproductive life, it is when it is painful, disturbing the patient. But when it is small and not disturbing the patient, there is no need of operation because in the menopausal there will be shrinkage. And when it is a shrinkage, those men of God of church, they say they have prayed for a woman and now there is no tumor. It is not that. It is because there is reduction of estrogen, then there will be reduction of that tumor. In those leiomyoma, it can be either intracavitary on the serosa, also on the myometrium. The dangerous one is intracavitary. With that intracavitary, there will be no pregnancy. Otherwise, leiomyoma, it is a benign tumor. The problem it is when it is intracavitary. This is the image of that leiomyoma. Rarely, you can have the leiomyosarcoma. This one it is malignant, but this one it is very, very, very rare. Where you see the malignant tumor of that myometrium. For the distinction, this one, malignant can have the mitosis. When you see the abnormal mitosis in uterine muscle, you may think about the leiomyosarcoma. In the case of leiomyosarcoma, there's some necrosis, cytotic atypia, and mitotic activity. Endometrial carcinoma, we have seen, appears most frequently between the age of 55 and 65. We have seen if it is endometrial hyperplasia at 55 years, it is a high risk of having endometrial carcinoma. They say the risk is obesity, diabetes, and hypertension, and the infertility. This is an image of the endometrial carcinoma, but most of the time they are known as endometrioid carcinoma. Endometrial carcinoma, we have said about it. As you have seen in general pathology, there's some mutation in those tumor of the endometrial carcinoma. There's some mutation, but this one is done on the molecular pathology. Most of the time we do the diagnosis, we do a staging, but when you go for further research, you do some sequencing and then you look for the mitosis. They say they are usually late metastasizing neoplasm, but dissemination eventually can occur. And the most common of clinical features of those tumors is bleeding, vaginal bleeding. This is a review question. Read it yourself. Any question about the body of the uterus? Any question before we go to the fallopian tube? Fallopian tube, the most common disease of the fallopian tube is called salpingitis. Salpingitis is an inflammation of the fallopian tube. The most common cause is microorganism. They say non-gonococcal infections are more invasive, penetrate the wall of the tube, and give rise to the bone infection and the seeding of the meningitis in the joint space, and sometimes the heart valve. Salpingitis increase the risk of tubal ectopic pregnancy. It can also be a cause of infertility. This is why you have to treat correctly salpingitis. They may result tubal ovarian abscess, and then they can make an obstruction of the tubercle, and then may produce permanent infertility. This is an image of the fallopian tube. This one, you know. Those of Syria, if you still remember. A primary adenocarcinoma of the fallopian tube, it is rare. It is not common. It can happen, but it is very, very, very rare. And when it is there, it can involve the omentum and the peritoneal cavity. As I have said, for every tumor, you have to check the mutation. It has black mutation. This one found also in the breast. But most of the time, we diagnose and then we do further research to predict the prognosis. Ovary, it has several types of the disease, depending on that histology of the ovary. It can be follicle, cyst, polycystic ovary, tumor, the surface epithelial stroma tumor like the serous, can be mucinous, can have the teratoma, and specialized teratoma in secondary tumors. So this one is if you still remember the histology of the ovary. Tunica albuginea, genuine epithelium, follicles, medulla where there is blood vessels, those follicles, corpus luteum, and this one corpus albicans. For every structure here, you can have a disease. Follicle and Endometrioid cyst. These they are found on the follicles. They say sometimes those cysts can rupture and producing intraepithelial bleeding and abdominal symptoms. And they are lined by granulosa lining cells or luteal cells. But as the fluid accumulates, pressure may cause atrophy of those cells. The size is about 4 to 5 centimeters. Clinically, what we found is the abdominal pain, pelvic pain. It will be the main complaint. And then you will do the ultrasound, and then you see a mass on the ovary. For example, on this image, follicular cyst versus inclusion cyst. This is a follicular cyst lined by those luteal cells, whereas inclusion, it is lined by that epithelium of the ovary. So don't be surprised when you've been in district hospitals. On the report, you found follicular cyst and then you found inclusion cyst. Make sure that you know that this one is lined by luteal cells and this one is on the epithelium of the ovary. And both are benign, they're not malignant. A polycystic, this one is like anomalies characterized by oligomenorrhea, infertility, and sometimes obesity may occur in girls after menarche, secondary to excessive production of estrogen and androgen by multiple cyst follicles in the ovaries. Commonly, it is known as Stein-Levander syndrome. In that case, the ovary has several cysts. The problem of that, it can cause infertility. Otherwise, it is benign, but the problem, it can cause infertility. Ovarian tumors, they say ovarian cancer is the 5th most common cancer. This is when it is in the USA. Here also it is. We don't have statistics, but it is. We see so many cases of ovarian cancer in South Africa. So they say 3-cell type make up the normal ovary. I've seen it, that one, covering epithelium, germ cells, and stromal cells. Pathogenesis, they say there are several risk factors for epithelial ovarian cancer. There are some mutation, like those black one, HER2/neu, KRAS mutation, and P53 is mutated. But the most common is the cause is unknown. I have seen it can be benign. There's also called intermediate or borderline, depending on the report. There's what we call low grade and high grade. There's what we call low grade cancer with limited invasive potential, what we call borderline, meaning that there is no spread. It is still on the ovary. Some benign tumors, there is what we call cystadenoma, which can be serous or mucus. Serous tumors, these are the most frequent of the ovarian tumor. Those cystadenoma, they are benign. Grossly, there must be small, large, spherical, or ovoid. The prognosis for the individuals with clear invasive serous carcinoma after treatment is poor. You can have benign cystadenoma is benign. Cystadenocarcinoma, this one is a malignant. For example, this one is classified as borderline with minimal invasion. This one is carcinoma. It is a malignant. We have those papillary structures. This is a serous carcinoma with a poor prognosis. There is what we call some bodies. These are calcification. They are found in papillary serous carcinoma. And you see the tumor now is involved in even the stroma of the ovary. A mucinous differ essentially from the serous that the epithelium consists of the mucin secreting cells. The mucin, it is like the epithelium of the intestine, whereas for the serous, it is like epithelium of the cervix. It can be benign or malignant. The prognosis of mucinous tumors is better than those of serous counterparts. So this is why when you say a cystadenoma or carcinoma, you have to say, is it mucinous or serous? You say serous mucinous because you see this epithelium, it is like an intestine. They produce mucin. This is why they are called mucinous tumors. It's what we call endometrioid tumors. They may be solid or cystic. Sometimes they develop as mass projecting from the wall of the cyst. Microscopically, there's a formation of tubular gland similar to those of endometrium. This is why they are called endometrioid. So don't be surprised when you report you found endometrioid tumor in the ovary. So it has features similar to that of endometrial carcinoma of the uterus. This one is the necrosis, inflammatory cells inside. This one is the fibroblascular core, and this one is the tumor. Another tumor, but not common, but I have seen some cases at Sashika. Brainless tumors, they can be benign or malignant. They contain a nest of transition like epithelium resembling that of the urinary tract, like this one. The epithelium like a transitional, like that one of the urinary tract. It can be benign or malignant. Another one, ovarian tumor, is teratoma. We have seen it in general pathology. Teratoma is what we call mature teratoma and immature teratoma. Immature teratoma, you have to grade it because it can be malignant. This is why when like a teratoma, is it a mature or immature? Immature, it has a poor prognosis. But they say the immature malignant variant is rare. They rise in the first 2 decades of their life, in the young female. Benign mature cystic teratoma. We can have some images here. It is where you found it from those sebaceous gland, bone, fibrous tissue, stratified squamous epithelium, and the others. Some hair follicles, teeth, and others. I remember I was at Ashibe, there was one lady from USA, a young resident in the gynecology. She found the teratoma, then she was crying that it is a discover. She has to report. He said, oh, we know this is one teratoma. He was asking why there is a teeth, why there is hair, why there is a cartilage. He said this one, it is normal. There is no need to report it because it is common in the ovary disease. So there are several types. Here I see the sebaceous gland, stratified squamous epithelium. The immature teratoma, it has foci of neuroepithelial differentiation. In this one, it is aggressive and it can metastasize. So the difference is on the microscopic. Distinguished feature is immature areas of differentiation toward the cartilage, bone, muscle, nerve, and the other structure. But those neuroepithelial differentiation, even on the image, immature neural tissue, like this one. So this one is the immature teratoma. When you see those rosettes of neuroepithelial tissue, this one it is immature teratoma. This is what we call stroma ovary. This one it is anterior of mature thyroid tissue. That may cause hyperfunction and produce hyperthyroidism. So don't be surprised when they say thyroid tissue in the ovary. So don't cry. For example, this one is those follicles of the thyroid. If you still remember the histology, here there's some fat. Even fat is teratoma, it's for teratoma. Because normally there is no fat in the ovary. In this one, there is a cartilage. They say one of these elements may become malignant. We have seen one case of the squamous cell carcinoma on the ovarian teratoma. Because of that epithelium has become the malignant. But this one, it is very rare. Most of the time it is benign. On the image here, you see the serous tumor, mucinous, brainer tumor, endometrioid tumor, and benign teratoma here. In the mature teratoma, this one on the grossing. Metastasis to ovary. About 3% of malignant tumors in the ovary are metastatic. The most common primary site is the breast, followed by large intestine, stomach, and other genital tract organs. And the most common tumor you must know for today is what we call Cochenberg tumor. This one, it is applied to the uniform enlargement of the ovary bilateral due to the diffuse infiltration of the ovarian stroma by metastatic signature cell carcinoma from the stomach. The commonest primary site is the stomach, followed by the colon. This one means that the primary site is on the stomach or colon. Then there will be metastasis in both ovaries. And this one is also found in a young female. And the term is known as Cochenberg tumor. This is an image of the Cochenberg tumor. You see the ovarian infiltration of those signature cells. This one. The primary tumor was in the stomach, and now it is in both ovaries. So the disorders of pregnancy, we have some those we call gestational trophoblastic disease. We have Irritable mole, invasive mold, choriocarcinoma, those preeclampsia. But what you must know, those that for more invasive mold or carcinoma, in that case, there is an increase of hormone beta STG, human chorionic gonadotrophic hormone. It is increased, and those most of the time there is a vascular chorionic village. I've seen it in your embryology, the outer trophoblastic and the inner trophoblastic. And this one, there is mesenchyme where there is blood vessels. You see those capillaries in the chorionic villi, meaning that they are normal chorionic villi. So in the case of molar pregnancy, we don't see those capillaries. Those core of fetal capillaries, they are absent. So for the placenta, you can have some inflammation caused by some microorganisms, mycoplasma, candida, or other bacteria from the vagina. This one is not even interesting. This inflammation is caused by pathogenous root, by those syphilis, tuberculosis, listeriosis, toxoplasmosis, those rubella, cytomegalovirus, herpes, is what we call TORCH, toxoplasmos, rubella, cytomegalovirus, and herpes. As a medical doctor, you must know what you call TORCH. Toxoplasmosis, rubella, cytomegalovirus, herpes virus. Those are involved in the placenta inflammation. Chorioamnionitis, this is the inflammation of the chorion with those amniotic fluid. It is caused also some days inflammation. Ectopic pregnancy, it can be found most of the time it is in a fallopian tube, but we can find also ectopic pregnancy even in the intestine. But the most common ectopic pregnancy is in fallopian tube. This is not even interesting. Let us see the gestational trophoblastic disease. That differ more invasive more and choriocarcinoma. Let us start by the identiform more. There are two types, complete and partial. In both, those chorionic are dilated, and there is, on microscope, absence of those capillaries, and they appear as grape-like. I don't know if you don't know what is grape. Like a vesicles. A complete identiform does not permit embryogenesis, therefore never contain fetal parts. All of the chorionic villi are abnormal, and the chorionic epithelial cells are diploid as normal. Whereas partial identiform more is compatible with early embryonic formation and have some normal chorionic villi and always is diploid and rarely give rise to the choriocarcinoma. Moles are most common before age of 20 and after 40 years. Elevation of STG in the maternal blood and abscess of the fetal sound on the fetal heart sound are typical. So in summary, those moles complete and identiform, there is no core of those capillaries. And partial, it has the fetal parts, and it is a triploid. These are the placental membranes, amnion, chorion. This one is what we call complete hydatiform mold, consisting of numerous swollen villi. You will see those in practice. This is what we call vesicles, grape-like. When you see this an image, be confident that you are dealing with a complete hydatiform mold. Those are villi. You see they are large, dilated, and no core of the blood vessels inside. This is a complete mold, no fetal capillary within the villi. Invasive mold, this one is very dangerous. Invasive mold means that those partial and the complete, they are remaining on the endometrium. Whereas in invasive mold, you will see those villi penetrating uterine wall, causing rupture and sometimes threatening of the hemorrhage. And this one, they can have local spread and spread to other organs, most of the time on the lung, brain. So once there is suspicion of invasive mold, you remove the uterus, and then you analyze, and then you found on the microscope those chorionic villi, they are in myometrium. In this one, you must be careful on the grossing, because most of the time you can't see it clearly. But what you have to keep in mind, this one can spread to other organs, from the uterus to the lung. It is difficult to remove completely by curettage, and therefore serum HCG may remain elevated. How to know if it is, if you have done the curettage of those molar tissue, and then you still having HCG elevated. If it's still elevated, please make sure that you are not in invasive mold. Another one, a malignant one, choriocarcinoma. In that case, you don't even see the chorionic villi, you see just a tumor. %50 of choriocarcinoma arise in complete hydatiform mold. 25% after abortion. Retain this, and then this one, in most cases, there is a bloody brownish discharge accompanied by rising titer of HCG. Even the treatment of the choriocarcinoma, when you give a chemotherapy, you have to monitor this HCG regularly. If it's still increasing, you may think that there is malignant cells are still there. When it's decreasing, you may say that there will be a good prognosis. Choriocarcinoma also can metastase, but they say lymphatic invasion is uncommon. But what you must keep this one is a malignant tumor. And there is a poor response to chemotherapy in choriocarcinoma that lies in the gonad. This one you have to underline. We have seen one case of choriocarcinoma in the testis, And the clinician has complained that the pathologists are wrong, saying that there is a choriocarcinoma in the testis. This can happen. So don't be surprised that choriocarcinoma in ovary and the testis. This is an image of the choriocarcinoma. You see the blood vessels, you see the malignant, but you don't see the normal chorionic villi. So they contain neoplastic, cytotrophoblastic, and methylnicate, trophoblastic, without villi. So this is what we call choriocarcinoma. Placental cytotrophoblastic tumor, these are uncommon. The most common are those more and choriocarcinoma. Can found those placental cytotrophoblastic tumors, but those they are rare. Eclampsia, preeclampsia, what you call Texemia pregnancy, is development of hypertension, proteinuria, and edema in the third trimester of the pregnancy. When you found a female with hypertension, proteinuria, edema on third trimester of the pregnancy, say that you are dealing with the eclampsia. But don't confuse that edema of the lower limb in pregnancy. Normally, this one is due to the compression of the inferior vena cava. It is not only, it is a preeclampsia. Eclampsia is where there is hypertension and proteinuria with edema. The main cause of this eclampsia is not known, but eclampsia is an emergency. Once you found eclampsia with those aggressive signs of hypertension, proteinuria, immediately you have to do the cesarean section. Otherwise, you will lose a baby and the mother. So this is why it is an emergency. You will see it when you be in hospitals. They say full-blown eclampsia may lead to dissemination, intravascular coagulation, with spread ischemic organ injury. So this is why eclampsia is potentially fatal. It is an emergency. This is a review of question. So for gynecology, you can stop here and then you can tell me if there's any question. Any question?
Question.
Yes.
I didn't understand well about doing the cesarean section in preeclampsia.
It is an emergency. You have to save the life of the baby and the mother. Because you have seen this. There will be spread ischemic organ of several organs. This one you have to make sure that you remove the baby. Once you remove the baby, there will be reduction of that hypertension, but you have to monitor the patient for about 7 days, because you can have also recurrence of that hypertension after 7 days. But the main cause, the cause is unknown. You see, there's several affected. There's some renal function is impaired. So this is why eclampsia is an emergency. Question? Other question?
Question next.
Yes.
Question.
You're welcome.
I would like to know the clinical manifestation of endometriosis so as to avoid the cancer.
Sorry?
Clinical manifestation of endometrial hyperplasia.
Clinical manifestation of those endometrial, most of the time it is the uterine bleeding. Uterine bleeding is the clinical features. The main clinical features, uterine bleeding. And uterine bleeding over 55 years, you have to exclude endometrial carcinoma.
So is there other thing other than endometrial bleeding?
You can have pain, pelvic pain, but the most clinical features is uterine bleeding.
Okay, thank you.
Other question? Question? Or you are hungry?
No question, Prof.
Huh? No question?
Yes.
No question?
Yes.
So if there is no question, we can stop here, then you go for lunch. Then we start at 2 with breast pathology.
Yes, thank you, Prof.
Okay. Bon appétit.
Thank you.
Merci.
Okay.